79th webinar of Pakistan Medical Association PMA, and with collaboration of Women Medical College Ahmedabad, Pakistan Physiological Society, Asian South Physiological Society, Azad Jammu Kashmir Medical College Muzaffarabad, and Pakistan Association of Pathologists. Before starting today's lectures and introduction of the Professor Akhtar Ali Khan, I will request Professor Rashid Saab to recite the Holy Quran. This holy month.
सर सूरह रात की आयत नंबर 28 तिलावत कर रहा हूँ. अऊज़ु बिल्लाहि मिनश शैतानिर रजीम. बिस्मिल्लाहिर रहमानिर रहीम. अल्लज़ीना आमनू व तत्मइन्नु क़ुलूबुहुम बिज़िक्रिल्लाह. الذين آمنوا وتطمئن قلوبهم بذكر الله ألا بذكر الله تطمئن القلوب. प्रिवेंशन ऑफ कोरोनरी आर्टरी डिजीज के हवाले से कुरान मजीद में एक बहुत अहम बात है. तर्जुमा में पढ़ देता हूँ. शुरू अल्लाह के नाम से जो निहायत मेहरबान रहम वाला है. ये वो लोग हैं जो ईमान लाए हैं और जिनके दिल अल्लाह के जिक्र से इत्मीनान हासिल करते हैं. याद रखो कि सिर्फ अल्लाह का जिक्र ही वो चीज है जिससे दिलों को इत्मीनान नसीब होता है. सदक़ल्लाहुल अज़ीम.
Thank you very much, Professor Rashid Saab. Really very nice recitation of the Holy Quran in this holy month of the Muharram. Today we are starting this very important lectures, essentials and more prevention of the coronary artery disease. Very common, one of the most commonest cause of death all over the world, not only in the Pakistan, is the coronary artery disease. Still, it is rising in spite of so many treatment, interventions, and modalities. Today, we are lucky that we have a Professor Akhtar Ali Bandesha. No need to introduce him, and very nice person, not only among the friends, but also among the PMA and others. Professor Akhtar Ali, over to you, sir.
Sir, thank you very much. Bismillahirrahmanirrahim. And thank you very much, everyone, to participate in this webinar. And I'm especially thankful to Professor Bukhari and Professor Salma Kundi, who gave me an opportunity to share my thoughts on prevention of coronary artery disease. And we will be talking about it in next 20-30 minutes. That is a very common disease, actually, and around 30% of the deaths worldwide, they occur because of the cardiovascular diseases, coronary artery disease especially. And this is in both genders, male and females. And this is the latest data, 2023 data, actually. And look, how can we compare the toll of the coronary artery disease deaths with the rest of the major ailments? You can see in different parts of the world, the red bar, which is representing the cardiovascular diseases deaths, actually, and how it is in the presence of the other ailments like malignancies, injuries, respiratory infections, chronic lung diseases, AIDS. They are much smaller bars. So all those, they make around 70%, and it alone causes around 30% of the deaths. It is a very alarming figure. And we will be talking in detail whether this is in the whole world in the same frequency and occurrences same in the different parts of the world, or certain areas they are having more coronary artery disease and less coronary artery disease other areas. So this is important. And this is 2023 update published in Circulation, and it tells that on average in someone in the United States dies of coronary cardiovascular disease in 34 seconds. And a stroke occurs in 3 minutes and 17 seconds. So this is a data in the United States. And how it is in the world, we can see this world map, actually. And the Delhi's per 100,000 persons, the red area and the yellow areas with maximum losses they are occurring. And this is not United States. This is the more of a Asia actually, and Oceania and all those. I'll be sharing the slides further. So it is a very common disease, and it's more common in our part of the world. And we know that there are certain risk factors which are associated with this. Cardiovascular diseases, they affect the heart or the blood vessels and can be caused by a combination of socioeconomic, metabolic, behavioral, and environmental risk factors. These include high blood pressure, unhealthy diet, high cholesterol, diabetes, air pollution, obesity, tobacco use, kidney disease, physical inactivity, and harmful use of alcohol and stress, and many more cardiovascular risk factors. And the studies or the recognition of these risk factors, it started around 80 years back, actually, 85 years back in 1945, Framingham heart study started in the United States, that person who are having cardiovascular diseases, are they prone to have because of certain risk factors they're having? And from 1945 onwards, we all know that how much data has been collected from different parts of the world and on different risk factors. So this was the first time that the world started studying, are there any risk factors? And now a robust data is there that these risk factors like diabetes, hypertension, cholesterol, and obesity, and all those, and then the different other risk factors, they kept on coming. And what is the latest, we will be sharing in next few slides. The recent study that has shown, inter-heart study and inter-stroke study, they showed that 9 and 10 common risk factors accounted for more than 90% of the risk of myocardial infarction and stroke, respectively. So this is the importance of this talk, actually, that we can prevent around 90% of the disease burden if it is properly done. And how it has been done in different parts of the world, what were the results, we will be sharing. Various research studies over the past 2 decades, in more than 80% of all cardiovascular disease events may be prevented by healthy lifestyle and management of known cardiovascular risk factors. So if we look at this slide, by adopting a healthy life, by consuming healthy diet, avoiding tobacco use, avoiding obesity, and reduce overweight, regular physical activities, these are the lifestyle changes which change these risk factors. And then treating certain risk factors like diabetes, hyperlipidemia, and hypertension, and use of aspirin and statins and certain preventive strategies like primary prevention and secondary prevention, both we will be talking. But look, there is a health inequity. Up to 80% of premature coronary heart disease risk can be prevented. The world has the tool and knowledge to mitigate harms to cardiovascular health, but too often the tools that can help the diagnose, prevent, and sorry, I have to change it. And treat cardiovascular diseases, they are not benefiting the communities who need them most. Around 4 in every 5 cardiovascular deaths occur in low and middle income countries. And the progress in cardiovascular health is increasingly concentrated in high income countries, a glaring health inequity that must be urgently needed. So 4 out of 5 deaths, they because of the cardiovascular disease occurring in low socioeconomic strata. And this is a slide which shows that how much money is being spent on health for the prevention of cardiovascular diseases in high income countries and in low and middle income countries. Can you compare more than $2,700 with $74? So how can you improve health without spending money? It is $1 million question, actually. Only health education by certain means, and definitely that will also include, that will involve the cost, actually. And then the treatment, we need to work on this thing, that how can we increase the health spending. So this slide shows that how many of the countries they are spending at least 5% of the GDP on health. And the 2019 slide, and high income countries, around 97% of them are spending around 5% of their GDP on health. And in our part of the world, it is around 50%. And that again is different in different countries of the Southeast Asia, East Asia, and Oceania. So we know that the countries like Pakistan, how much money are we spending? It's less than 1% actually of the GDP. So how can you improve health with spending of so little money? I have a strong reservations on this health policy. The transition of the population, it has played a role actually. By 2025, 61% of population will be living in urban areas in developed countries and fewer in developing countries. Urbanization results in adaptive or maladaptive lifestyle changes and variable societal changes. Greater prevalence of chronic non-communicable diseases with lifestyle changes occur. And developed countries, urbanization is accompanied by economic growth, enhancement of urban infrastructure, increased spending on social services, education, healthcare, and positive lifestyle changes. But contrarily, developing countries, the rapid urbanization and the presence of inadequate infrastructure results in urban slums and greater socioeconomic disparity. So this is an area which needs to be taken care of. And what happens while we are changing from the more active village life to urban life? The nutrition shifts with increase in energy consumption in urban areas, with increase in all types of fats, decrease in whole grain and fibers, but increased consumption of fruit and vegetables. Changes in food production, prices, and availability, that is contributing. Changes in nutrition strongly influences individual and population health. So this is what happens with the diet of the persons who are with the passage of time with urbanization. And activity level, there is reduced physical activity generally. Obesity is increasing, diabetes incidence is very dangerously increasing, and consequently the cardiovascular diseases. And changes in lifestyle and leisure activities has occurred. Less energy expenditure at work, and leisure with advances technology and more vehicles. So less walk, and you are spending more time in front of the screens, TV, computer, phone, and etc. And due to changing job styles, increase mechanization and reduce activity. So reduce activity is it's the number one challenge in 21st century. The people, they are spending more time while sitting and less physical activity. This is more dangerous than smoking. So American Heart Association in 2010 launched this Life Simple 7 program, and this includes this is actually the 7 parameters. Actually, they plan that we will be working on these 7 parameters, and by working on these, we will be reducing 20% disease burden in next 10 years by 2020 in American population. And they were successful in this. And what are those? We will be talking in details. These are 4 modifiable risk factors: smoking, healthy eating healthy, weight reduction, and physical activity, and 3 biometric measures like blood pressure, cholesterol, and blood sugars. These 7 factors are classified in 3 categories. In an ideal situation, how should be the blood pressure, how should be the cholesterol, and physical activity, how much level it should be, and what is the intermediate, and which is the poor biometric actually, or poor state of the 7 risk factors. Individuals with the ideal levels for all 7 metrics are considered to have ideal cardiovascular health. So The American Heart Association 2020 impact goal of improving the cardiovascular health of all Americans 20% while reducing deaths from cardiovascular disease and stroke by 20%. This was their motto. And it shows that it is never too late to adopt healthier behaviors. So by changing our lifestyle, by working on these factors, we can improve our overall cardiovascular health. And the evidence shows that 50-year-old with ideal cardiovascular health has substantially lower lifetime risk for cardiovascular diseases and markedly longer survival. Several surveys have shown that very few American adults have ideal cardiovascular health. Look at this is in America, and how is in our part of the world, we can well imagine. Perhaps as few as 1% of the population, they have an ideal cardiovascular health in relation to these 7 factors. In fact, only 18% of adults have 5 or more metrics with ideal levels, with lower prevalence among men, 11% compared to women. So women, they had a better cardiovascular health overall. It's more than double than the men actually. Studies have also shown that people who meet 3 to 4 of life's simple 7 measures reduce their risk of heart-related death by more than half. So it does not mean that if a person is taking care of his high blood pressure, taking care of the diabetes, and is a little bit overweight and it does not find exercise, is not getting benefit at all. It is not the case. It's a cumulative benefit by all these risk factors. So working on 1 will be giving benefit, working on 2 will be giving more benefit, working on 3 will be giving more benefit in the ideal cardiovascular health, while the ideal 7 biometric and other risk factors. However, an AHA Nielsen study showed that most people do not know their life simple 7 numbers. Most US adults overestimate their health, heart health. 39% of people surveyed thought they were an ideal cardiovascular health, whereas studies show that only roughly 1% of Americans actually have ideal levels for all 7 metrics. Based on the science of Life Simple 7, AHA has also created My Life Check. It is actually available online, and you can put in numbers of your own, your cholesterol, sugar, blood pressure, smoking history, and all those, and you can calculate your own ideal health. My Life Check leads user through a healthy assessment that identifies the greatest opportunity for improvement and generates a personal heart health score and a customized action plan. When used in the workplace, My Life Check can support workplace health by providing employees with custom recommendations to track and improve their lives. Simple 7. So the companies, if they work on the heart health of their employees, they probably will be saving their spendings on medical reimbursements. If we look at individually what is the ideal smoking risk factor management, it is that someone has never smoked or has quit smoking by more than 12 months. So a person who has quit smoking more than 12 months and has not smoking, they are equal actually. It is not the case with the lungs, where the smoking does cause a damage in a permanent way actually. It is not the case here. So if a person stops smoking, he will have his better cardiac health in future. So never tried, never smoked, whole cigarette and all those. This is ideal situation. If he has quit smoking, but is within 12 months, he will be at a relatively more risk, and this risk will wane with the passage of time after 12 months or so. But if it's a current smoking, he's a poor candidate. BMI, we all know that it is the actually the method to estimate the weight of the person, whether it's overweight or not. And the ideal BMI is between 8.5 and 25, and 25 to 30 at 29.9 is intermediate risk, which comes in the category of the overweight, and more than 30, it is obesity, and then moribund obesity if it's more than 36 or 40. And so the risk of cardiovascular diseases that increases with the increase in the BMI. It's a relationship actually which is linear kind of. And the physical activity, it's very important. The latest recommendations are that the person should be doing moderate level of exercise, at least more than 150 minutes per week, or more than 75 minutes per week vigorous physical activity, or more than 150 minutes per week moderate exercise with 2 times vigorous physical activity, or 60 minutes of moderate or vigorous activity every day. So this is ideal. So the concept is, if someone is having a time to do exercise at night, no problem. If evening, no problem. 10 minutes, no problem. 50 minutes, no problem. This will have a cumulative effect. So 15 minutes in the morning, 30 minutes in the evening, it will make around 45 minutes of physical activity. Moderate exercise means where you, while you are doing exercise, you have increase in your pulse rate, you have some kind of breathlessness or physical activity, which gives you a little bit of knowledge that I'm doing some exercise. If you go around with your normal speed, go through the bazaar and all that, it will be a walk, but it's not a moderate physical activity. And ideal is this one, more than 150 minutes per week, and less than that is intermediate. And if it's not exercising, it's a very bad a problem actually. So healthy diet, I will be talking in my later slides actually. Total cholesterol numbers, less than 200 milligram, it is ideal without diabetes I'm talking about. And 200 to 239 is intermediate, and more than 240 total cholesterol is a poor indicator of cardiovascular health as a one risk factor. Blood pressure, less than 120 and less than 80 is an ideal. 120 to 140, it's intermediate. 80 to 90 is intermediate, and more than 140 and more than 90. Again, this blood pressure relationship association with its complications in the form of heart attack, stroke, renal dysfunction and all that, that is a linear relationship. The more the blood pressure, the more the chances of having these complications. And by treating the number of high blood pressure from 180 to 160, 150, 140 will gradually reduce the incidence of these complications. So it does not mean that a person has had a blood pressure of 190 by 130 and now is having 150 by 100. So he is not getting any benefit. He is getting benefit. And then other thing is, if someone does not have a required numbers with maximum medicines, continue medicine, do not stop medicine, because that has been found to have been effective. Diabetes is an area which needs to be looked at much more detail, because it is a disease which is not only the glucose numbers, but is a pro-inflammatory condition as well. The people who have diabetes will be having a more dangerous cholesterol. So this is, even if they have less than 200 cholesterol, they will need statin therapy for that, because it is a pro-inflammatory condition. So diabetics, the diabetes control with the drugs, with physical activity, lifestyle modification, all that, and statins. This is how we can change the prevention, the prevalence of the cardiovascular disease, our primary prevention. So this is summary again: get active, lose weight, control cholesterol, reduce blood sugar, eat better. I will be talking in detail in later slides, and manage your blood pressure and stop smoking. This is Life Simple 7. This is the repetition of the same slide. And according to the American Heart Association 2022 heart diseases and stroke statistics update, approximately 121 million people in the United States have high blood pressure, 100 million have obesity, more than 28 million people have type 2 diabetes, and only 1 in 4 adults reported achieving the physical activity and exercise as recommended. This is America, and we have risk factors which are comparable to the rest of the world, are not better than them in a lot of areas. Like diabetes, we are much worse actually, and control of blood pressure and all those. And this Life Simple 7, it was such a huge success in reducing the incidence of the cardiovascular diseases that they changed it in 2021 with the Life's Essential 8 by incorporating a healthy sleep actually into these 7 factors. Sleeping 6 to 8 hours a day is important for cardiovascular health. We will be talking in detail in later. So sleep have been added in addition to cholesterol, smoking, diabetes, hypertension, physical activity, overweight, eating habits, and all those. So if we look at the detail, what type of diet quality for adults and children, there are 2 levels of intervention. One is at the individual level and one is at the population level. At the population level, it is for the research and public health purposes, and for individuals, it is for healthcare and dietary counseling. For individuals, the Mediterranean eating pattern for Americans is used to assess and monitor cardiovascular health. The MEPA is a DASH-style eating pattern that can be measured with 16 yes or no questions about the weekly frequency of eating olive oil, vegetables, berries, meat, fish, dairy, grains, and more. And what is the DASH diet? It is at the population level, dietary assessment based on daily intake of elements in the dietary approach to stop hypertension eating pattern. This DASH style diet score has 8 components: high intake of fruits. The person must have fruit or salads in every meal. A sizable portion of their meal should be with fruit or vegetables. Or nuts and legumes also must be used a little more. More whole grain and low fat dairy is recommended. And low intake of sodium is recommended. Red and processed meats and sweetened drinks, they should be used less actually. Nowadays, we do not say that you eat animal, definitely the animal fats must be avoided if they are in comparison to the plant fats, but the problem is we recommend that take less fats, and while we actually use these oils for cooking and different types of foods, while the temperature of the fats that goes beyond its boiling temperature, it converts into trans fats. So if a person is using a little bit of butter or anything on his bread just to make it soft, that is better than to make a paratha actually, which will result in the burning of that. And then what is the difference between a good fat and a relatively not so good fat, as the concept is that olive oil is better. Olive oil is better, but if you burn it, it will lose its battery quality. So we do not recommend a lot of these, and less sodium is okay. We do not say that do not eat any sodium or any salt, but less salt is recommended. They can have red meat, but less meat actually. So this is important. And then using more, at least 2 fish, 2 times use of fish in a week is recommended, especially the oily fish is recommended. So more fruit and vegetables and nuts and fish, that is recommended, and less fats, use of fat, and not to make parathas and these kind of use of the fats, and less sodium and less red meat is recommended. This is a general dietary recommendation in latest guidelines. Physical activity, we have already discussed that it should be at least more than 50 minutes in a week with moderate physical activity or more per week, and 75 minutes per week of vigorous intense physical activity for adults, and the optimum level is 20 minutes or more per week for children age 6 and older with age specific modification, younger children. So the children already are very active, but it should be measured in minutes actually. So they must be working more and more physical. Less time on laptops and mobiles and all that. Please make your children more mobile, more outgoing actually, rather than sitting in homes. This is the area of the bad effects we will be seeing in future. Nicotine export, use of inhaled nicotine delivery systems, which include e-cigarettes or vaping devices, added since the previous metric only monitored traditional combustible cigarettes. This is Life's Essential Aid 2021 program actually. So e-cigarette is also inhibited, and we are looking at its very bad effects in recent days, and they have been, especially disposable kind of vaping system, they are being thrown out of the market by governments in Europe. So I hope we do not take their thrown out things now, because we see a lot of vaping shops opening in different markets and all. So we have to learn from the others' mistakes and do not repeat the same things. This reflects use by adults and youth and their implication on long-term health. Life Essential Aid also includes secondhand smoke exposure for children and adults. So passive smoking also is dangerous, and it has been recommended that it should be avoided for the ideal cardiovascular health. Biometrics, the body mass index, it is an imperfect metric, yet it is easily calculated and widely available. Therefore, BMI continues as a reasonable gauge to assess weight categories that may lead to health problems. So ideal BMI we have already discussed, that it should be between 18.5 to 24.9. And the writing group notes that BMI ranges and subsequent health risk associated with them may differ among people from diverse racial and ethnic backgrounds and ancestry. So this is important sentence, that everyone cannot get an ideal 18.5 to 25 by BMI, because if we know that there are certain sizes of the skeleton. One is having a lean body, the other is having a fat body. Actually, this bony skeleton system we have been taught in our medical schools, that someone is having bones which are much broader, so he will be having a little more. So, and likewise in different parts of the world, the people, they do have obesity issues or genetically. So this aligns with the WHO's recommendations to adjust BMI ranges for people of Asian or Pacific Islander ancestry, because recent evidence indicates the risk of conditions such as cardiovascular disease or type 2 diabetes is higher at a lower BMI. So it's an interesting statement actually. Lipids, metric for blood lipids, cholesterol triglycerides is updated to use non-HDL cholesterol as the preferred number to monitor rather than total cholesterol. HDL is the good cholesterol, and recent study, one study actually showed that HDL as a good cholesterol may not be giving you as much benefit as we have been expecting in the previous times. Other forms of cholesterol when high are linked to cardiovascular risk. This shift is made because non-HDL cholesterol can be measured without fasting beforehand, thereby increasing its availability at any time of day and implementation at more appropriate points, more appointments, and reliably calculating among all people. So non-HDL cholesterol is easily measured in the laboratory. There's nothing difficult to write about it. Blood glucose, we have discussed that HbA1c is also recommended, and blood glucose levels are also recommended to be monitored for diabetes or pre-diabetes. HbA1c can better reflect long-term glycemic control. Blood pressure criteria remain unchanged from Association 27 guidelines that establish levels less than 180 and 120 by 80 as an optimal blood pressure control. Hypertension defines blood pressure more than 130 and more than 90 actually. So sleep duration is associated with cardiovascular health, more measured by average hours of sleep per night. The ideal level is 7 to 9 hours daily for adults. Ideal daily sleep ranges from children are 10 to 16 hours per 24 hours for age 5 and younger, and 9 to 12 hours for ages 6 to 12, and 8 to 10 hours for ages 13 to 18 years. And then more than 18, it must be at least 6 to 8 hours. It is associated with better heart health. The novel risk factors, we have been talking about these parameters in the past as well, from 20 years or so: homocystinemia, hyperuricemia, elevated serum fibrinogen levels, CRP levels. Nowadays, the talk on this is by doing exercise, by being more physical, actually, you are changing your inflammatory markers of the cardiovascular health. So two persons of the same age with similar risk profile, if one is exercising, the other is not exercising, the person who is exercising will be having, if we take their blood samples, they will be having less inflammatory markers like CRP and all those in comparison to the person who is not exercising. And because of these lower levels of inflammatory markers, they will be having less damage to their endothelium, cardiovascular endothelium, and less cardiovascular disease. So this is how the exercise and rest of the lifestyle changes, they transform. Very new risk factors we are talking about nowadays from last 2-3 years is non-alcoholic fatty liver disease has been linked to cardiovascular diseases. It is also the most common chronic liver disease in developed countries. A 2017 meta-analysis revealed a 77% higher risk of cardiovascular events and over double the risk for coronary artery disease in patients with non-alcoholic fatty liver disease. So fatty liver is not so benign thing as we have been saying in the past. More recent prospective study revealed that patients with non-alcoholic fatty liver disease had greater than double the risk of cardiovascular events. So double is a lot of figure actually. Wherever the double comes, it's changing the whole landscape of the disease act. Patients with liver fibrosis had a 4-fold increase in cardiovascular diseases. Chronic kidney disease has emerged as an independent risk factor for coronary artery disease, and diabetics and hypertensive, they have a very high incidence of chronic kidney disease in our country. So the people who have diabetes, they will have multiplication of the risk of disease by cardiac events by having chronic kidney disease. Pro-inflammatory mediators, oxidative stress, and decreased nitric oxide production leading to endothelial dysfunction have been reported as possible mechanisms. Silent myocardial infarction occur more commonly, likely due to higher incidence of diabetic and uremic neuropathy in patients with chronic kidney disease. CKD with a GFR of 15 to 59 is noted as risk enhancing factor in the American Heart Association guideline for primary prevention of cardiovascular disease. So it should be more than 60 actually. SLE has been found to be associated with the increased incidence of cardiovascular disease. Probably it is because it's a pro-inflammatory condition actually, and it affects on the coronary microcirculation as well. Pericarditis is common manifestation of SLE. Rheumatoid arthritis have a 1.5 to 2-fold increased risk of coronary artery disease in rheumatoid patients. So traditional risk factors such as BMI and lipoprotein levels also showed more unpredictable pattern in their predictive accuracy in the presence of RA. So mechanism behind the associated risk is likely through a pro-inflammatory effect. Rheumatoid arthritis is also listed among the risk-enhancing factors in the American Heart Guidelines for primary prevention of cardiovascular diseases. Inflammatory bowel disease, a 2017 meta-analysis noted that IBD is associated with high risk of coronary artery disease. However, The results were interpreted with caution due to the heterogeneity of the studies. The mechanism of the risk was uncertain, but again, it was thought to be due to chronic inflammatory states. So inflammation in one way or the other is the mechanism which results in the endothelial injury and cardiovascular events. HIV is understood to come with a high risk of cardiovascular disease and its associated sequelae. A 2018 expert analysis from American College of Cardiology noted that patients with HIV showed a 1.5 to 2-fold increased risk of coronary artery disease. The mechanism again was based on a pro-inflammatory state. Thyroid gland intricately links to cardiovascular function. It is a master gland that affects all the hormones in the body. Proposed mechanisms include the effect of thyroid hormone on dyslipidemia, cardiac function, atherosclerosis, vascular compliance, and cardiac arrhythmia. This is an area still under study. Guidelines also vary on their screening recommendations for thyroid disease, hypothyroidism, and subclinical hypothyroidism. So, but more work is needed on this. In 2014, the FDA released a required labeling change for low testosterone products for the use of low testosterone due to aging, due to a possible increased risk of heart attack and stroke. So subsequent studies and reviews have not been consistent in this correlation. Some reviews have even indicated a potential beneficial cardiovascular effect when treating low testosterone with testosterone supplementation. Further study is needed to provide more clarity on this topic. Vitamin D deficiency has been increasingly studied and debated over the past decade. It has a link with the increased risk of coronary artery disease. Further studies, however, have not confirmed a beneficial effect on vitamin D supplementation, but it has association with depression and all those. Further studies needed to clarify whether vitamin D supplementation is truly beneficial or for coronary artery disease prevention. Socioeconomic status is a significant risk factor for cardiovascular disease. Upstream determinants include financial strain, lack of affordable and nutritious food, exposure to domestic violence, and inadequate housing. This is an important consideration to consider given existing cardiovascular disease risk equations do not capture this. We had a recent study from my own institution, I had conducted it, and around 80% of the people who underwent in a public sector hospital for angiography and angioplasty and had coronary artery disease, they belong to the low socioeconomic status. Although the people with low socioeconomic status, they are predominantly entering into the public sector hospitals because of the financial issues. But again, it is an important factor that so many people, from the low socioeconomic status, they are having cardiovascular disease, especially the coronary artery disease, having heart attacks, having deaths, having disabilities, and the work loss and all those. So what a bad effect at all. Women and coronary artery, this is a new thing. Although men are at high risk than women for coronary artery disease, is still the leading cause of death among women also. So 29% of the females worldwide die because of the cardiovascular disease. Among women, only 54% were aware of this in 2009. Women were found to have non-obstructive coronary artery disease in around 57% of cases. So this is very important. The woman may have a normal coronaries and angiography, but is still having coronary artery disease, which we call as a microvascular disease, which we cannot see on the angiograms. But this needs to be treated in the 50% of the cases, while the men, they have more obstructive disease. So proposed mechanism for include coronary microvascular dysfunction, altered endothelial tone, structural changes, and altered response to vasodilator stimuli. Estrogen is thought to have a protective role in coronary vasoreactivity and is also theorized to promote plaque stabilization via an anti-inflammatory effect on atherosclerosis. So estrogen deficiency probably puts women more at risk of cardiovascular disease. Lack of awareness and understanding coronary artery disease in women has also led to a disparity in health outcomes. There has been more focus on obstructive coronary artery disease and men compared to women. So women are less predominantly will be presenting in hospitals. They will be brought in hospital only once they have a very severe problems. So this in an underestimation of the disease. On 2012 article reported a decrease in cardiovascular mortality across all age groups in men and an increase in cardiovascular coronary artery disease mortality among young women less than 55 years old. The use of aspirin, statins, ACE inhibitors, ARB, and beta blockers in primary prevention has a very significant role, especially in high-risk patients. Aspirin used to be given in the past to everyone who is more than 45, but now it has been very clearly understood and decided that aspirin should only be given in high-risk patients like diabetics or who have had multiple risk factors, because it turned out to have less protective effect and more side effects of GI bleed and all that. So this is not the case, but this is the case with the statins now. We are using it with more liberty. It does have a very safe safety profile, and it is more effective not only in reducing the cholesterol levels, but because of its anti-inflammatory effects, it has a benefit beyond cholesterol lowering. So the people can use it more safely than aspirin for primary prevention, and definitely in secondary prevention, aspirin and statin, they both are very, very much recommended. ACE inhibitors and ARBs and beta blockers, because of their pleiotropic effects, are anti-inflammatory effects. They have a role in primary prevention when is recommended, like in hypertension cases and all that. So a lot of other risk factors, they are there, but I stop here and we can discuss now things.
Professor Akhtar Saab, and so many questions are there. And also we have the answer of these. And I will advise the people to, if you ask the question, you can raise your hand. And Dr. Shabir Saab, can you comment something? Dr. Shabir Sheikh, Professor Shabir Sheikh Saab. Sir, can you unmute and give comments on this? The senior cardiologist.
Assalamu alaikum.
Sir.
Mulazam Sahab, really excellent lecture. I will comment regarding microvascular angina in female. I have a lot of first study I did in round about 92, 100 females in Mayo Hospital who have a typical effort angina. 50% had positive ETT. At that time, we don't have the stress thallium to add the simple ETT. And we did in all these 100 females coronary angiogram. All those who are even typical history and positive ETT, they have non-obstructive coronary artery disease. Number one. Number two, 15% who have this obstructive or mild coronary artery disease were those patients who are on, number one, either diabetic, hypertensive, or taking contraceptive pills.
No.
Yes.
So these contraceptive pills, post-menopausal even, taking this Premarin and life on order, which is basically is no more recommended for hormone replacement therapy. This is a high-risk patient. My son in Adelaide, who is interventional cardiologist, his PhD topic was microvascular angina. So they did this, most of 90% of the patients were female. And they have this provocative. Now in the AHA guidelines, they have including that every female or male who has a typical effort angina, a rest angina, even positive stress thallium or simple stress thallium and had a non-obstructive coronary artery disease must undergo provocative study. What is this provocative study? In the cath lab, they produce this, inject a certain amount of microgram of acetylcholine. And over 80% of these females, the males, they have microvascular, they become immediately go into spasm and ST elevation.
Yeah, yes. Thank you so much, Dr. Shabir. Thank you so much, Dr. Shabir, for your comments. Really,
I'm really
this-
thankful, Malazam Sam, for your effort of doing all these.
you are welcome, sir.
Thank
Sir,
you,
you are
sir.
very senior. I think, as the Professor Akhtar has told, that 90% of the things we can control. And if we adopt these 7 factors, hopefully this lecture, we will upload this on the website and on our Google and also our Facebook and also our other areas, so
I
that
can send you the whole studies of regarding microvascular angina
sir.
and provocative method.
Yes, sir. Professor Rashid Sahab, we have only 5 minutes to finish this topic.
Okay,
So you
thank you.
can ask the question, sir. Professor Rashid sir.
जी सर, बहुत शार्ट सा क्वेश्चन है आफ्टर अली साहब, बहुत अच्छी प्रेजेंटेशन माशाल्लाह।
सर आप पूछें। जी
जी, आपने ये जो किया था ड्रग्स टू प्रिवेंट, उसमें ओमेगा 3 फैटी एसिड्स का रोल है उसमें?
So international audience are there, sir. Can you ask the question?
Right. Okay. Is there any role of omega 3 fatty acids?
Yes, the role of omega-3, the omega-3 fatty acid is there, but the newer generation, new omega-3 fatty acids, they have been found to be effective. The omega-3, which is found in the cod liver oil, actually, it needs to be taken in such a huge quantity that which is not possible, because it results in loose motions and all those things. But the new formulations of the omega-3 fatty acids, they have come and they are effective and they can be used in everyone actually.
Thank you, sir. Anyone else? Anyone, or if anyone else want to give any comment on it, because really it was a really
somebody
elaborative and PG Professor
somebody
Salman.
questioned in the chat box about role of antioxidants.
Yeah.
Yes, ma'am. On antioxidants, I have mentioned in my talk as well. Because this plaque formation is lipid peroxidation along with inflammation. So antioxidants, as the gentleman has mentioned about this omega-3 fatty acids, they have antioxidant effects. But the real drugs actually, like trimethazidine, which is an antioxidant, their no role has been documented as in primary prevention.
Dr. Akhtar Ali, Professor Akhtar Ali, really the corona has taught us so many things, that there is a big role of inflammatory things or drugs or other things which are produced by our inflammations. If we reduce these inflammatory markers in our body, which are produced by our diet or our lifestyle, we can reduce these factors. Because we have seen that even after COVID, there are so many post-COVID patients which are failing the cardiac diseases due to these inflammatory markers, which we are measured during the COVID. So I think Dr. Akhtar Saab, can you give final comments to finish today's lectures? Dr. Ayaz Somro, sir, thank you so much for your nice comments. Dr. Ayaz Somro Saab.
Sir, thank you very much. Can you listen me?
Yes.
Yes, sir, we are clearly listening.
Thank you so much, Dr. Bandesha. I am really appreciating you for your wonderful talk. आपने ये जो बात कही थी हेल्थ पॉलिसी के हवाले से, तो जब मैं आपकी टॉक सुन रहा था तो आई एम नॉट अ क्लिनिशियन, आई एम फिजियोलॉजिस्ट, आई वर्क एट यूनिवर्सिटी ऑफ सिंध। तो मुझे बहुत ही जो है ना वो मजा आ रहा था आपकी टॉक में कि पाकिस्तान के जो टॉप के क्लिनिशियंस हैं वो कार्डियोवैस्कुलर डिजीज के बारे में इतना अपने आप को अपडेट करते हैं, और अमेरिकन की जो गाइडलाइंस हैं वो जो है उनसे भी उनकी वाकफियत है। लेकिन अगर उसको हम अगर कॉन्टेक्चुअलाइज करें तो आपने बहुत एक अच्छी बात कही कि हेल्थ पॉलिसी के हवाले से कि हेल्थ इक्विटी होनी चाहिए। तो हेल्थ पॉलिसी बेसिकली जो है वो उसके अगर हम प्राइमरी इंग्रेडिएंट्स देखें तो उसमें उसके जो पहला उसका कॉन्सेप्ट है वो है एविडेंस बेस्ड रिसर्च के हो क्या रहा है। ठीक है, एविडेंस बेस्ड रिसर्च के बाद हमारी नीड असेसमेंट होती है, और नीड असेसमेंट के बाद स्टेक होल्डर एंगेजमेंट होती है, उसके बाद इक्विटी और एक्सेस का प्रॉब्लम जो है वो उसमें इनकॉर्पोरेट होता है। फिर वो पॉलिसी कितनी कॉस्ट इफेक्टिव है या कितनी सस्टेनेबल है उसके बारे में सोचा जाता है। फिर उसके बारे में जो है वो रेगुलेटरी फ्रेमवर्क बनाया जाता है, गवर्नमेंट के रेगुलेटरी बॉडी होती है वो हर चीज को रेगुलेट करती है। फिर इंट्रा सेक्टोरल कोलैबोरेशंस होती हैं, न सिर्फ मेडिसिन का मसला है लेकिन ये पब्लिक हेल्थ का भी इशू है विच इज पार्ट ऑफ मेडिसिन ऑफ कोर्स। और जो हमारे जो इंजीनियरिंग के हैं लोग उनका भी प्रॉब्लम है क्योंकि हमारे यहाँ जो सिटी इंफ्रास्ट्रक्चर इट आल्सो प्लेज रोल।
very important. Very important.
Very
बिल्कुल,
good. Very good.
पब्लिक हेल्थ अवेयरनेस जो है वो भी जरूरी है, और वो जो हेल्थ पॉलिसी है उसको मॉनिटर और एवेल्युएट कौन से प्रिंसिपल्स पे किया जा रहा है वो भी जरूरी होता है, और पॉलिटिकल विल और लीडरशिप होनी चाहिए, इंटरनेशनल कोलैबोरेशंस होने चाहिए, फ्लेक्सिबिलिटी और एडाप्टेबिलिटी होनी चाहिए। ये 12-14 इंडिकेटर्स होते हैं हेल्थ पॉलिसी के जो हेल्थ पॉलिसी बनाते हैं। तो पाकिस्तान में अनफॉर्चुनेटली जो मेडिकल की जो रिसर्च है उसमें बहुत सारे अच्छे लोग होंगे, लेकिन अनफॉर्चुनेटली मेजॉरिटी जो रिसर्चर्स की है वो सिर्फ परसेंटेज पे पेपर बनाते हैं कि हाँ जी इतने आए इतने गए जो है वो, बाकी इतने बचे, ये होता है। जैसे आपने कहा कि अगर मैं कार्डियोलॉजिस्ट होता यहाँ पर तो मैं इस स्कीम पे अपने पूरे जो इलाका है उसको एवेल्युएट करता कि मेरे इलाके में जो आपने लाइफ 7-8 स्किल्स बताए उस बुनियाद पर इस क्राइटेरिया पे कितने लोग उतरते हैं कितने लोग नहीं उतरते, उस पर एक अच्छी रिसर्च पेपर अच्छा रिसर्च पेपर होता है या उस पे मैं अपनी फाइंडिंग शेयर करता। आपने बहुत अच्छा काम किया है कि एक इनिशिएट किया है, एक जो है वो ठहरे हुए तालाब में पत्थर फेंका है। तो आई वुड लाइक टू सजेस्ट एवरीबॉडी एल्स इंक्लूडिंग मी के हमें इन चीजों पे काम करना चाहिए ताकि हम एक अच्छी हेल्थ पॉलिसी देखें। जो पॉलिटिशियंस होते हैं अनफॉर्चुनेटली उनको हेल्थ के बारे में कुछ खास पता नहीं होता। अब लियारी का एक मिनिस्टर है जो फेडरेशन का चलाता है, बेसिकली ही इज नॉट अ हेल्थ पीपल पर्सन, लेकिन फेडरल गवर्नमेंट ने जो है उसको हेल्थ मिनिस्टर लगा दिया। अब उसको एक पूरा देखें बाहर के मुल्क पे पूरा एक डिपार्टमेंट होता है उसमें PhDs होते हैं, वो मिनिस्टर ऑफ हेल्थ होते हैं, उनको सब कुछ पता होता है, लेकिन हमारे यहाँ
Dr. Somro, apologies, the things are going to the politicized, and I think your
Can I have a few comments on Dr. Somro's suggestions? Actually, these are very valid points. Actually, you have mentioned, and some work is being done at all levels. Government is not only the health minister; it's a huge infrastructure of the ministry. Actually, different departments. And their sub-segments and the association and a lot of it is a big thing. Federal government is a big thing. It's not a one man, number one. Number two, the policies they are made by the professional. Then the societies like Pakistan Cardiac Society, Diabetes Association, all those, our duty is to recognize these risk factors. There to suggest the government for the policy making and give them recommendations and all that. And I am part of Pakistan Cardiac Society, and I have been vice president Pakistan Cardiac Society a few years back. And my duty was to work on the preventive side of the cardiology in Pakistan, throughout Pakistan. So Khawar Kazmi from Karachi is heading this preventive side from Pakistan Cardiac Society. Diabetics Association, they're also working. The people are working, and the data which we are sharing of the international, actually, we have the consistent data, and we are the clinicians, we are treating our patients as well daily, and look at the magnitude of the problem the patients are having. How many stents and how many bypass surgeries has been done in last few years. So how can you, a population of 25 crore, 225 million people, how can you put everyone to stand and bypass surgery? This is the only solution is prevention and working on the guideline and
Yes.
the factors we have discussed.
Very true, Professor. At the end, I will ask Umar Ali Khan, President of Pakistan Physiological Society. I was reading some of your chats. Can you give the comments, because we have a very short time to conclude today's session. Professor Umar Ali Khan.
Thank you very much, Professor Lazim. Thank you. Wonderful talk from Dr. Bandesha. And we hail from the same medical college. We are both Nigerians. I requested that if we can have developed our own guidelines,
Yes.
so that, you know, we can have our own standards as Pakistanis, as our culture is very different from Americans. And
Yes.
secondly, as World Cup is approaching, we would like to have some Bandesha Saab guidelines what to do while we are watching Pakistan-India cricket match for cardiac problems.
Definitely.
Stress is a very important risk factor, actually.
Yes.
And
Yeah.
Biggest
yes,
risk.
and how to cope with the stress. Drugs is one thing, but this is psychiatrist and psychologist will give you the more insight into the understanding of this problem and how to cope with the stress.
The stress is very important. Dr. Sarwar Pirkani Saab from Pakistan Association of Pathologists. Can you give the comments, sir? Professor Pirkani Saab, are you there, sir? Okay. If अभी आप नजर आ रहे थे. Any of Professor Salma Kundi, can you conclude today's session? Very nice session.
Okay.
Lot of questions.
Thank you so
but we have
much.
very short of
Thank
time.
you, Malazim sir. I'm so grateful to Professor Dr. Akhtar Ali Bandesha Saab. On a weekend, he's taken out his precious time and guided us. And through this, what we have taped, through this link, all our students would be benefited. And let's work on these 8 things, and we can write good papers on it and make national policies and move ahead, inshallah. I'm so very grateful to you on behalf of PMA, on behalf of Pakistan Physiological Society, SAP, which is South Asian Association of Physiologists, the Pakistan Pathological Society, the AJK Medical College, Muzaffarabad, and Women Medical College. Thank you, Bandesha Saab. Allah bless you, and Allah bless all the participants and the attendees. Have a great weekend. Pakistan Zindabad.
Thank you so much, madam. Allah Hafiz. Allah Hafiz.
Allah Hafiz.
जी अल्लाह हाफिज.
Allah Hafiz.
मैंने अकबर से कहा भी था कि दोपहर को सालन फ्रिज में रख दे, उसने रखा ही नहीं, गर्मी से खराब हो गया. मैं अंदर करके ला दिया.
बहुत काम शुरू हो गया. नहीं खाना है डॉक्टर.
बुढ़िया चली गई, परसों साया नहीं गया बस. अम्मा किधर हो गया? देखो रास्ते, अगर आप तुम्हारी बड़ी भाभी, अगर वो आ गए तो क्या हो गया?
कुछ भी हो गया, लेकिन को अच्छा नहीं करूंगा.
अरे तो मेरा आना है. मेरा क्या है? मैं देंगे ले.
इस प्रोग्राम होते हैं. ये तो हम बाद में बात करते हैं.
देखो मेरी ये आदत नहीं है. इतना देखे उनकी शिकायत है. लेकिन मेरे को कुछ अच्छा नहीं लगता कि बेटा मेरी बातों ना
और टीचर में आज बात हुई नहीं।
हेलो,
लगता है लोग कुछ ज्यादा ही मसरूफ हो गए। फोन उठाने की फुर्सत ही नहीं है।
उठा तो मेरा फोन।
तो आप उठाए ना रात को। मैंने तुम्हें शाम में भी कॉल की थी।
कुछ कैसा लगा था?
कॉल
कोई बस बाबा के कुछ दोस्त थे अपनी फैमिली के साथ आए थे, तो मतलब कुछ खाया?
हाँ यार, खा लिया था। तुम्हें पता, दुकान भी खाता हूँ मेरा फोन। अब घर का खाना बहुत ज्यादा याद आता है, और स्पेशली तुम्हारे हाथ की स्पेगेटी।
नहीं, तो रेसिपी भेज दूंगी तो प्रैक्टिस करने तो फिर तुम भी वैसे बता दो।
जी नहीं, सारी जिंदगी में स्पेगेटी तुम्हारे हाथ की खाऊंगा, सुन लो तुम।
तुम तारीफ हो मुझे बर्तन मैंने अब मैंने बोला था मैं नोट आके मैं चलती हूँ।
अच्छा चलो, यूके मैसेज कर देना।
हाँ ठीक है, वापस।
रूबी, ओ रूबी। रूबी मैं जा रहा हूँ।
कार्ड कितने की है कितने अच्छा राती नहीं है